Welcome to RhAPPcast, the official podcast of rheumatology advanced practice providers. I'm your host, Amanda Mixon. This podcast is where we tackle the latest advancements, clinical pearls, and hot topics in rheumatology care to help you elevate your practice and improve patient outcomes. Today's episode is titled, Elevating Care in Lupus Nephritis, What the New ACR Guidelines Mean for Patients and How APPs Can Apply Them. Lupus nephritis is, of course, a very challenging condition, and the recently updated ACR guidelines bring new strategies for optimizing care. We're here to unpack those guidelines and discuss actionable insights and advanced practice providers like you. I'm thrilled to be joined by Monica Ritchie, a true expert in the field and a valued RhAPP faculty member. She was also one of our initial board members. So, Monica, welcome to RhAPPcast. Now, obviously, we've known each other for what feels like forever, but for our listeners who haven't had the pleasure of meeting you, would you mind introducing yourself and telling us a little bit about your background?
Sure. My name is Monica Ritchie. I'm a nurse practitioner here in New York. Currently, I'm working for Northwell Health, which is a huge health system here in the city, in Long Island. So it comprises of a lot of areas here. I'm one of the 2 nurse practitioners here in the rheumatology practice, and we have almost 30 rheumatologists. I started my career in rheumatology as an infusion nurse, actually. And after I finished my master's, I was invited to stay, and that was a hospital for special surgery as a nurse practitioner. So that's where I actually initiated my career. And I was taken by one of the docs there at the lupus center, and that's how I got my passion for lupus. I did a lot of educational research stuff and always up on the front of educating patients. I think the best way to get a great outcome is to educate the patients on the why we're giving them so many medications to begin with. Very passionate about that. And then, part of an amazing family at RhAPP for I don't even know how many years now. I forgot. 2018, I think, or 2019.
2019. It was right before the pandemic.
Yes. So very, very happy to be here with you guys.
Well, obviously, Monica, you're, I think, downplaying yourself a little bit because I really do truly think of you as like the lupus guru. And I know, but, when I've had really challenging lupus cases, you are the one that I reach out to. And I would reach out to you over, of course, a lot of the colleagues that I work with, because I think you have taken care of very, very sick people and very challenging. And I think it just proves what an APP is capable of and, how important we are to the care of these complex conditions.
Oh, 100%. I think that we take very good care of our patients in all of our very complex diseases, MPs, APAs, all the APPs, alongside pharmacists. We do a tremendous job. We do a marvelous job in taking care and really getting to know our patients. It's not just prescribing. It's not just making that diagnosis. It's really knowing that whole patient and make sure everything goes well for them in their whole entire life, for sure. Yeah.
Absolutely. And I think that's why it is so important that we understand, what these new guidelines mean. So, obviously, I'm super excited to have you today. I have been wanting to have you on our RhAPPcast for a while, so I can't think of a better podcast to have you on. So let's dive into the new guidelines and explore how we can apply them to deliver the best care for our patients. All right, so I'm just going to get into a bunch of questions for you because, again, you are the lupus expert, in my opinion. You are. You very much are.
But thank you.
And for anyone that's listening, I do have her cell phone number, so you can definitely reach out to me and I will get that for you. She loves doing curbside consults. So
Have fun.
All right, so right into it. Okay, so the new ACR guidelines emphasize preserving kidney function while minimizing medication-related toxicities. So how do these updates mark a shift in the way we approach lupus nephritis treatment compared to the previous guidelines?
I think that, it's always I think that the first thing is like it's prevention, right? I mean, there's no really prevention, but just early diagnosis in a way. The timing is important. The longer that lupus nephritis or that inflammation stays on the kidney, the more kidney you're gonna lose, right? I think there was some slogan, "Time is kidney," at some point. I can't remember where it was from, but this is a really truly statement, right? Time is kidney. When you get a patient who has, and I recently saw a young man who probably had lupus nephritis for at least a year, and the damage is there. I cannot change the ever take back that kidney, right? And that's a 24-year-old that's seeing PCPs and nobody knew what was wrong with him. So by the time he got here, obviously biopsy just confirmed my diagnosis, but the damage is there. So I can never turn that back. And we know that, if you get one hit in your kidney, that is, that's a serious business. And particularly with young people, we don't want that 85-year-old kidney on a 20-year-old person. So we want to preserve it. We want to get there. We want to do always the check for the urine. We always want to know if there's any indication of proteinuria in the urine very early. The issue with the new guidelines is that they just go for broke, right? In a way, they go for triple therapy right from the bat. They don't say, "Oh, let's do pulse and let's do MMF, and then if that doesn't work, let's go for this or for that." No. They go for the kill right at the beginning, which is in my opinion is the right thing to do, right? You start the triple therapy, you really need to save that kidney as early as possible. And I think that's a divergence from previous guidelines where you try one thing and then if it doesn't work, you try another thing and you keep going into steps. There's no steps. There's one step and it's the triple therapy.
Yeah, I mean, I think too, it's important. I think previously, and again, you can really speak to this because, you've done this for quite a long time and taking care of a lot of these, really sick patients. But it really used to be that we would, unfortunately, sometimes have to have people on like high doses of steroids for a long time. And I know I was reading through the guidelines and it really wants you to get down to 5 milligrams within 6 months. I mean, it's kind of like pulse them for 3 days.
Yes.
Don't go higher than 40 and then
Exactly.
get them down to 5 milligrams.
Yes. Yeah. They really want to, take a little bit of a load of steroids, which is our go-to drugs on those patients and minimize, the amount of exposure you have in such young people with steroids. 40 sometimes is possible, and I have to say 40 sometimes is not possible, right? And that's the pulse, right? They're trying to get the pulse in to get some of the load out. I'm a hit and miss with that 40, I have to say. Sometimes it's possible depending on how much protein there is in the kidney. But overall, that the new guideline is just go for the pulse, and then start with the 40. So that's all a shift because before it was just go for the oral. So that's also different from the previous guidelines.
Well, and I think it just like these are guidelines, right? Like obviously that doesn't work for every single patient because every
Exactly.
patient is not, that
Right.
one
Yeah.
case or whatever. But again, I think it's just important to just kind of acknowledge and realize that steroids are life changing for people, but I say this all the time to my patients. It's not a question of will you have toxicities from the steroids, it's when and how bad will they be. And so it is kind of nice to see that. And to your point, you already kind of mentioned this, but this early detection, right? Like trying to get it, time is tissue, all of those things. And so the guidelines tell us about screening and performing kidney biopsies. So I guess this is a little bit two-part, but how do you feel like APPs can really implement these guidelines? And then how do you do it? What do you do in your practice?
I mean, I'm pretty independent, just like you, right? I mean, I have to say that I commit the crime of bypassing the nephrologist many times. I would just schedule for them biopsy because it saves a step. And then by the time they get to the nephrologist, they get the pathology in hand, and then I can work together with the nephrologist. But I usually just if there's any more, I have to say a little bit more strict, 0.4, and I don't like it. I'm like, you know what? Let's just kill this where it is, and I send for the biopsy, and then I engage the nephrologist afterwards. Sometimes I have to say that I also commit the crime of starting mycophenolate way before the biopsy results are in, which I have done quite frequently. I like, this is lupus nephritis. Let's, not waste a lot of time here. Let's just start the medication, counting that you have insurance issues until everything gets done. So I already kind of start, if I have any hint that this is truly lupus nephritis, is that, she was having her period, which sometimes, freak us out. I was like, oh no, there's a lot of blood and protein in the urine. Like, no, I was having my period. So taking some of those, little scare here and there, I don't play. I just start therapy right away.
Well, I think, again, that speaks to your experience, like managing these really sick patients, and again, I totally agree. And, you actually kind of taught me that, like, it's okay to get the biopsy yourself. Like, you don't necessarily have to wait to
No,
get them into nephrology, because sometimes that can be a lot of
months.
time. And so
Yes.
I think one important potential piece to this is, okay, if you see a patient with lupus and you're now finding, protein in the urine, to your point, maybe even 0.4 makes you say, well, we should probably do a biopsy. But if you're starting to see that, and, just to order it. So figure out in your system how to order it. I mean, I know
Exactly.
it's still a procedure. Of course, there's still risks, but if you are concerned about that patient and it's going to be 3 months to get them in with nephrology, just do it, order it. And then potentially from there, you can do it even a curbside with a nephrologist, or call, or know your nephrology APP that's
That's it.
working,
That's it.
and
That's
say,
it.
hey,
And
this
you
is what I'm
can
thinking.
just text message, hey, can you see it? Because even if you send to the nephrologist, the first thing he's going to do is send for the biopsy. It's not going to
Right.
be anything different than that, right? So I kind of, like, as I said, my first step is just send straight for the biopsy, and then I send for the nephrologist. I want things done very quickly, because, as we mentioned, time is tissue, and you need to get running on the biopsy, and you need to get running on that treatment.
Absolutely. And, again, I think it just speaks to the importance and the urgency that we should have. I was reading one study that said, up to, I mean, it was a high percentage, and I don't want to just say it wrong because I don't have it in front of me, but it was a lot of our lupus patients will develop
80%.
lupus nephritis. Um,
80%.
and that to me
At
is,
some
I guess it
point
was,
during their disease, yeah.
that's I mean, it's astounding. Like, wow, we really need to be on top of that. And so, it really says, in terms of, if you have I don't want to say a regular lupus patient, because I don't think there such exists, but for your lupus patients, we really should be doing urine tests. Like, if they have no history of kidney problems, etc., every 6 months. And
That's the
so
guideline. The Monica
yes,
guideline is every time they're in your door, which is for me is every 3 months. I make sure they come in. I don't have a lupus patients that come in every 6 months. I don't. I don't believe in the 6 months follow up. I see my lupus patients religiously every 3 months, and every 3 months they get a urine test. Um,
perfect. And
so
then that spot urine to, protein to creatinine
exactly.
ratio, and
Yes.
making sure. And then from there, you just get on top of it. And
That's
so,
it. That's it.
y-
That's. I think at some point there was a study that were giving the urine sticks to the patients so they can monitor themselves at home for any signs of protein, which I think is actually a great idea. Like, hey, you see anything in your urine, call me. But in the absence of that, it's for me, it's every 3 months. That
gosh, I don't
that
know.
that is one disagreement that I have with the guideline is the every 6 months.
I don't know that I'd want to, like, give my opinion. I don't know. I'd be a little afraid that I'd be getting phone calls all the time, and it's like,
Probably
oh,
will. Yeah,
is it a clean cat? Like, I don't know, but I love. I mean, and again, Monica, I always learn so much from you, and I take that back with me to practice, because I do take care of a lot of young women, with lupus, and
sure.
knowing what to do. But I agree with you. It's nice to say, like, hey, at your very least, you should be doing this every 6 months, or
At
if there's a
least.
change in their renal function or something. But, like, if I do the same thing. If I see a patient every 3 months, I will just do a urine, because
That's
why
it.
not?
Yes, exactly.
And so I totally agree. Okay, so let's shift a little bit now to talking about the specific, therapies. So you already mentioned it once, but triple immunosuppressive therapy is really highlighted for active lupus nephritis. So can you walk us through what this regimen entails? And even another piece of this is some of the barriers that you might see to implementing care, which
So
again, we could
many.
probably have a podcast just talking
Only
about
on
that for
that,
hours.
that alone is going to be huge, right? So off the bat, you have your pulse, you have your oral prednisone, then you get your biopsy. Hopefully you start the prednisone, you saw a gram of protein, you already put them on the pulse. And then you send them for the biopsy and you get your biopsy mycophenolate. And then, you're going to add either the belimumab or the calcineurin inhibitors, and rhyme or reason, really, for me, it depends, it's like how much protein you're, right? The calcineurin inhibitors work very fast. So you will see a decrease in the proteinuria very, very quickly on patients with calcineurin inhibitors. And that's what we saw in the trials, very quickly decreases the proteinuria. The belimumab will take at least 6 months for you to start seeing movement. So it all depends how acute the biopsy is. And that's why I always, teach all my nurse practitioner students that biopsy, you should know every line. You should know what is, everything, the chronicity, everything that is in there, every cell that is in there is important because that is really how you're going to guide your treatment. Right? If there is a lot of inflammation, if there is like over the top stuff, calcineurin inhibitors, mycophenolate, that's the way to go. If it's a class 3, but it's not super acute, it may go for the belimumab. It's hard to say because each patient is so individual. So I can't say, oh, you do this for this or this for that. It's really your as a clinician, your experience that is going to dictate which way to go, and the insurance company, which is your biggest barrier these days is the insurance companies. So they're going to say, oh, but the good thing is now you have the guidelines to fight with. So you at least can say, no, this is what ACR is telling me, so that is something that gives you a thing.
Absolutely, yeah.
So that's barrier number 1. Barrier number 2, I would say mycophenolate, calcineurin inhibitors, great combination, too many tablets. Right. So compliance becomes a serious issue where you really have to do a lot of education, a lot of hand-holding with the patient so they actually take the medication. Right.
Yeah, absolutely. And to your point, I think you even mentioned it right at the very beginning of this was like, you talk so much about how you educate your patients on advocating for themselves and also understanding why it is so important to take their medications. And again, I think that's that establishing the rapport with your patient and so that they trust you to know that, hey, I need to do this or else I could get really sick and I could end up needing a kidney transplant. And so absolutely, I would totally agree. Do you ever? I'm curious. Do you ever use? Because I have not. Full transparency, I have not. Have you used this low dose cyclophosphamide, or do you kind
Thank
of
God
steer?
did not steer clear
Yeah,
from it. It's more and more losing more refractory really medication. So I have to say I will go for rituximab prior to go into cyclophosphamide. So on CD20s, they're there in the guidelines as well. Refractory, I would try that just because it's young women. It's not light medication, right? It has serious repercussions down the line from reproductive system, particularly. So it's something that's always in the back of my mind. Particularly, even with the low dose, you will have some issues with reproductive health in young women. So I tried to stay clear. I tried to try everything else. Unless I really have to. And I think most rheumatologists, at least in my practice, are kind of like working with cyclophosphamide less and less.
yeah, I would agree. I unfortunately have not had to use it, and that we always talk about like when do we have an attending get involved and et cetera. For me personally, I would not feel comfortable doing cyclophosphamide by myself, and so that's when I would at least be calling my collaborating physician and saying, hey, how do I do this, or do you feel like I should be doing this? Because to your point, I mean, there are of course, when it's a life or death situation, you have to choose whatever's going to save the patient's life.
Absolutely.
But there are those long-term repercussions that you also have to consider. So,
Yeah. Yeah,
all right.
definitely.
So again, we talked about a little bit about the steroids. So tell me, Monica, how do you get people off steroids? Like, what are you doing? Please teach us all so that we know
Oh my God. That's
how
a
to
$1
do it.
million cast. I have to say that once I have the patient on my dose of mycophenolate, I would say for a month, and God willing, they're able to tolerate the full dose, and I do a blood work and things are starting to come down, I start to taper down prednisone. I'm going to go down 10 milligrams every month if I can. Sometimes even quicker if the patient really responds to the combination, whatever medication they're on. I see a decrease in protein, I start pulling off the steroids. There are patients that linger. Yes, it comes with the territory, right? Sometimes you never get to that 0.5. Sometimes it's very hard. You're adding the medication. So 6 months is kind of like a tight, very tight. Um, Not always possible, I have to say. But I am very quickly, once they are at least in one medication, I start tapering the prednisone.
Yeah, so
That's
it's
my thing.
kind of like try to do it as fast as you can. Obviously, you're monitoring these patients so closely that
Right.
when you can. And again, there's always going to
And
be those
also
circumstances
it's
where you
gonna
just can't.
depend on what else is going on, right? Because with lupus it's not just lupus nephritis. They may have lupus nephritis with thrombocytopenia, with leukopenia. And, as I said, it's not always possible. You know what I'm saying? It's not just one complication that is going on at a time with lupus patients, right? You can have a million different things going on at the same time. So it all, the steroids is not just there, but if we're just talking about lupus nephritis, I try to really taper down fairly quickly.
So, what about our kids and our older patients that we're taking care of? I mean, I personally don't do pediatric at all, so I can't really speak to like what I would do in a child with lupus nephritis. I mean, that sounds horrifying and absolutely so complicated. But are there any strategies that you might have for either really young, and obviously, if that's not your area, then totally I understand that, or like really old patients that develop lupus nephritis?
Definitely don't see kids. We see them on transition at age 18, and kudos to all the pediatrics, APPs and pediatric rheumatologists out there because boy, it's a tough situation, right? Definitely minimizing the exposure to cortisone at a young age is key. And now they have more approvals, thank God, for lupus and lupus nephritis. They have a lot more into their belt that they had before. So I think the same guidelines that apply to us with the kids, minimum amount of exposure, start therapy right away, and you see that they even use triple therapy. So it's kind of like and kids sometimes get even more medications than adults. Like depending how seriously they are. We used to work with a pediatric rheumatologist, and he used to do Cytoxan followed by rituximab followed by MMF. So he just wanted it gone. And they're very resistant. Thank God for that. But you need to really minimize as much as possible. I mean, we've seen the effects of patients who started, prednisone very early, and this is a forever kind of deal. So definitely follow the guidelines to minimize the exposure and use all the medications that you have available. Definitely more
Absolutely.
familiar with older age adults that is a problem in so many levels, right? Major risk for infections, polypharmacy, confusion because there's so many medications right now. So on my end, I try to minimize maybe infusion versus too many pills with the elderly. So I can, what I'm saying, minimize the amount of pills that they're taking because they're not just taking my pills. They're taking blood pressure pills. They're taking cholesterol pills. They're taking diabetic pills. They're taking a million pills. So in that particular end, I'm more careful with how many tablets I'm prescribing. And, make sure there's a family member, if possible, always in the visit or somebody that I can email and say, we're changing this or you're changing that, because that's when confusion really starts. But, I try to really minimize tablets. And I try to, if possible, not always possible, I try to go for infusion. So, it's one less things for them to worry about, if possible.
Well, and sometimes with Medicare, it kind of works out that way anyways. So,
Exactly. Yeah.
I totally agree. So, the other thing too is that the beyond these kind of immunosuppressive guidelines, they talk about really managing the cardiovascular health and infection risk, which I think is really important, because
Absolutely.
we need to be managing these, or not, maybe not us managing it, but at least, understanding that there are other things that go along with having lupus. And so, I mean, do you agree? Do you think that's really important that they
Oh,
talk about these?
absolutely. Of
Yeah.
course.
Yeah.
Vaccines, if you're going to do physical triple therapy, you need to vaccinate. It's the first step, right? You can go ahead and start your whatever it is that you're starting on, but you need to start the vaccines as well. You need to make sure that person has a shingles vaccine, has a pneumonia vaccine at least, flu vaccine every year, whatever else, that is indicated for that age and for that particular condition. I think vaccines are super important. With the triple therapy, you cannot play. Um, be there young, much bigger risk with the elderly population, obviously. So the vaccines I don't discuss with the patient like you have to take it. It's an
Yeah.
unfortunate thing, but you have to take it because the risk of infection is much higher with the triple therapy, obviously.
Right. Well, and also, like, again, them managing their other issues, right? Like if they already have diabetes and we're putting them on these high doses of steroids, like, so I think the most important thing too is just to make sure we are working with their other providers, their primary care, to make sure that they are, being monitored. I mean, I can't even begin to tell you how many times I've said to a patient, "Oh, well, who's your primary care?" And they say, "Well, you or
Yeah,
I
yeah,
don't know,
yeah,
you
yeah,
are." And
exactly.
I'm
Yeah,
like,
I hear this every day. Yeah, I'm like, but you're managing. I'm like, no, you still
no,
need
no,
the
no, no,
primary
no.
care. Yeah.
Yeah, like I'm not managing those things. Like you need to make sure that you're doing that. So I totally agree. And then I guess my last question for you, which you've already touched on, so I know what you're going to say, but the guidelines highlight the importance of shared decision making to address patient values and preferences. So you are so good at this, but what advice can you offer APPs for fostering this kind of collaborative approach, especially in managing these complex cases?
I think that, one thing about APPs is we always get to know our patients, right? It's not just a patient, it's somebody with a life, kids, whatever, dreams, plans for the future. And as APP, we all go there. We all know their family. We know, you know what I'm saying? It's a very friendly environment. And so if I doing something with any medication, I'm like, hey, tell me about your plans for pregnancy, or are you planning on getting married? I try to get as much as information as possible so I can judge. And then I'm like, look, these are our options. Which one do you think it fits best? And if that whatever they want is not possible, then I'm going to have to negotiate, like, okay, I know you're dying to get pregnant, but this is not the moment. Give me a year. I need to get this has just happened to me and a patient who's like dying and she just developed like dying to get pregnant. Not she was dying, but she was dying to get pregnant. They had just got married and developed lupus nephritis. I'm like, you cannot do that. And I go, my heart will not tolerate this. You cannot do this. So we had to have a conversation with her. We have to bring the husband in so he could understand what was going on, and that I needed time. So it's always a negotiation, it's always understanding where the patient is coming from, knowing their background, knowing their culture, and APPs, we do that naturally. I think that's one of our biggest gifts is that, we're not scary people. So the patients always open up for us. But you have to meet the patient where he is, right? And the patient needs to understand that sometimes things have to be postponed. So it's an open conversation always with my patients. All side effects are on the table right off the bat. And so, we have to postpone pregnancy with postpone pregnancy. I cannot postpone saving your kidneys, so sometimes it's a tough conversation. And I'm sure you had your share of tough conversations with your patients where it's like, it cannot happen right now. I'm sorry, but this has to wait. Right. And sometimes it's doable. So it all depends where the patient is, where the disease is, and again, what the insurance let me do with that.
Absolutely. So it really what I'm hearing, which of course is just meeting the patient where they're at and then working with them to achieve what they want, also keeping in mind that we're trying to obviously keep them alive and healthy. So I I couldn't agree more. And, again, it's always so lovely to talk to you. Thank you for answering all these questions. I'm sure this will be truly helpful to our listeners. With that, it wraps up our episode today. So, Monica, thank you again so much for joining us and sharing your expertise. And not only talking about the ACR guidelines for lupus nephritis, but also kind of how you interpret them and what you do. I mean, I truly believe your insights are so invaluable. And again, I know that our listeners are going to take so much away from this. And again, it's just so meaningful because they are guidelines. And so it's super, to your point, it's really helpful to have these when we're fighting with insurance companies or when we just kind of want to know what to do because, again, so much of us are very independent and out there kind of doing it. And so to have something that says, okay, this is what I should be aiming for, I think can be helpful. So with that,
100%.
Is there anything else that you'd like to leave us with before we wrap up?
I think that, as you mentioned, always know your APPs, all the other specialties, your rheumatology. We're a very tight group. And I think that we should always help and support each other. So get to know your nephrology APP, your primary care APP, and it's a much easier communication that way to get patients in and out and, less waiting time and also just for treatment options as well.
Well, and I guess I would just kind of say also, too, this is a really good reason to come to our conference. If you've not been and you're listening, Monica will be there to answer all the lupus questions. She tries to get out of the lupus lecture every year and we won't let her. So you just keep doing the lupus lecture. We're forever and ever. But also it's a really great opportunity to do just that, to connect with us. We all are a very tight-knit group and we love to help each other. And so anyways, I had to put that little plug in. And also, if you enjoyed listening to this, please don't forget to follow us on our RhAPP social media for updates, education, resources. We are on X and Instagram at RhAPP, and you can connect with us on LinkedIn under Rheumatology Advanced Practice Providers. Of course, you can visit rhap.org. You can access, we have a ton of digital education coming that is there. You can explore professional opportunities and just really learn about what RhAPP has to offer, which every year just gets bigger and bigger. If you have not done so, please download our RhAPP ACE 2.0 mobile app, which, again, there's message boards, there's digital education, and so much more. So if you're looking to expand your rheumatology knowledge, check out our free online training course. Also, a step up to rheumatology. It's packed with 36 hours of lectures, 700 assessment questions, and really is designed to help you build your expertise. I have to say, I have taken, I do lecture on the course, as do you, Monica, which I'm so thankful for. But even as an APP that has a lot of experience going to that course, which is free, I'm able to learn about things that I don't really see that much of. And the lovely thing is it's all APPs teaching APPs. And so I feel like we really do know what we need. And so, I don't know, I think it's just such an amazing, amazing course. So again, thank you so much, Monica. I love you dearly.
My pleasure always to be here with you guys.
You're such a good friend of mine. But before we started this, I was actually saying at some point, Monica and I shared our locations with each other. And so if I'm ever feeling lonely for Monica, I just get on my phone and say, where is Monica now? And sometimes you're in Brazil, sometimes you're in New York. Who knows where you are?
Exactly.
But anyways, well, thank you again for tuning into RhAPPcast. I'm your host, Amanda Mixon. So until next time, friends, we'll see you soon.